leave this for later, but this is a moment of eruption. And eruption is vertical phenomenon, okay? Eruption is not anterior-posterior phenomenon, okay? So have this in mind, just to warn you guys a little bit. And first molars will be the primary factor to define what we call intercuspal position, okay? So the intercuspal position is critical now to give all the functional patterns and completely change the input of the masseter, of temporal muscle, in lateral pterygoid, medial pterygoid, all the function, all the masticatory muscles will completely change at this moment because the input of the new contacts from the first molar is completely different than the input contact of the deciduous dentition. Okay? So have this in your mind. So structural change in the joint will follow the craniomandibular system. It means that what happened to the teeth will naturally happen adaptation in the joint. So the joint is completely dependent on the good quantity or nice eruption of the teeth. And later on, of course, with them in occlusion, we have input from the functional system, the muscles, and everything surrounding function, okay? So this is very well explained in video. So how is our, flush area on the deciduous molars? So if it's straight flush, if it's like a distal step, mesial step, we can go from here to class 2 or change to class 1 and so on. Here's the point that they really check how is the position of the second molar to guide the eruption of the first permanent. But if we change this position, we can always facilitate and allow this patient to be class 1. Or in class 1, I mean not only the teeth, I mean bones. Bones in good position, in physiologic position. In molar is important to what? To maintain the vertical dimension, protect the joint, and guide the mandible in function in three dimensions. The only teeth that will guide the mandible in this period of time from 6 until almost 12 years of age is the first permanent molar, okay? Because we don't have bicuspids and we don't have canines to guide anything in this period of time. So we have only molars permanent and deciduous dentition, okay? So after that, we have a very important role of the incisors. So we need to be careful with the incisors position as well. Not only the molar, so if we don't have intercoronal space between upper and lower, if we don't have a good pathway for the incisors to work, the mandible will also be blocked. So if I have a very retroclined incisor or a very over-erupted upper incisor, it causes a fencing on the mandible, and the mandible is not capable to adapt anteriorly. And the patient starts to adopt a new position, a more posterior position of the mandible, because the incisors interference is very painful and very harmful, and the patient will always avoid this contact. Nobody chew on incisors, okay? So we will always avoid incisors. Then the mandible will always stay backward, causing a dramatic extreme class 2, okay? In joint problem. So the concavity of the upper central incisor position, the lingual concavity or palatal concavity of the upper incisors, guides the lower into protrusion and sideway, okay? So this way, calculate the position of the lower, the inclination of the lingual concavity of the upper incisor are super critical to understand that they are controlling the mandible closing. So we have basically two controls at this moment. The first permanent molar, which is limiting the closing on the posterior area. But when we close, if we go back here to a very old law, the Page law, the law of Page. So when the patient closes, we have one first contact on the molar, and the incisors guide you anteriorly. So incisors not responsible to make a stop in closing, but the incisors are responsible to function forward and to the side. okay? So in perpendicular rotation of the mandible. So depending how is the position of the molar and the position of the incisors, I will have adaptation of the mandible in this complex. Sometimes I can fall into a class 2. Sometimes I can go and slide forward into a class 3. So it's completely dependent on the position of the upper first molar and the incisors condition, okay? We can have a big compensation in the mandible position. So here we see now, after this short, very brief speaking about this, this is a topic that I can talk here for months. So this is a very important thing to understand, that when the molar erupts, it erupts much more in the posterior area, much more than the incisors. So the occlusal plane, if I make a tracing, a line between upper molar and upper incisor, this line with the time of eruption, it drops on the posterior. It means the posterior area, vertically speaking, or quantity of eruption speaking, with time becomes bigger than anterior portion. So it means the occlusal plane descends a lot on the posterior area, and this is the way that the joint can be capable to adapt, have a free space to develop. And here also come the eminence, okay? So we are talking about a patient who borns without eminence. We have zero eminence, and this eminence will be formed later on, okay? So based in what kind of decompression of the joint we have during the eruption process, okay? So based on that, this is a very dynamic process. Sometimes you can have different inputs on the left and the right, and at the end, I will have different, let's say, morphology of the joint left and right. We also have to have in mind that condyle is a secondary growth center. The secondary growth center is capable to adapt through the life. Okay, so it means that even when I have an adult patient, if I introduce in this adult patient some change in occlusion, the mandible will adapt, the condyles will adapt, okay, in a good manner or in a bad manner. So sometimes we adjust the joint, the occlusion, the joint responds so good. And sometimes if I just do not change very well the occlusion, and the forces of occlusion leads to a compression in the joint, this system will also adapt, but in a bad way, okay? So summarizing, we born class 2. To be a class 1, I need a process of adaptation in eruption. And when I receive, for example, in my office, a patient class 2, the patient never become class 2, because we born class 2, we just stay class 2, okay? So we stay class 2 since we born, and later on, by adaptation, we can be a class 1, and further on, extra adaptation to be a class 3. So it's a process of adaptation, but adaptation of what? Eruption and bones position, okay? So in transverse sense, because this is a sagittal view, we have very important to understand that the bones in the frontal view also grow transverse way, very dependent on occlusal forces and occlusal input. For example, here I have a cone DCT of patients, and you can see here how is the inclination of the upper molar, which is always with the Wilson curve positive, so the upper crown must be in positive torque, and the lower molars also in a little bit negative, so it makes the Wilson curve become positive, and it is absolutely in line with the bone's structures. So this force is able to be distributed to the zygomatic bone, and the whole thing will adapt this way. So we have like pillars of supporting of forces on the maxilla in the zygomatic area here. On the lower, we have the bones of the mandible aligned to be the mandible is not straight and upright, the mandible sideways is always a little inclined because of this. So we need to have this the distribution of forces through the bone. So we can see clearly here how the forces are distributed to the maxilla. So because of this, we need a sequence of positive torque, or let's say positive Wilson curve for every single element. 7, 6, the 4, and the 5, and the canine, they are in a progressive Wilson curve from the second molar to the canine. Okay? This is important. Why? To distribute the forces, to have the forces in our skull being well distributed and all the bones can adapt nicely. So basically, this is what we have in terms of inclination in a high vertical patient or high angle patient. Usually this distance is a little bit narrow because the distance is larger, the patient is long face. When I have a short dimension face, like in the yellow here, arrows, this line tends to incline more because this distance is shorter. Okay, so it's usually easier to see, let's say, deeper Wilson curve in low angle faces than we see in high angle faces because of the distance we have. So malocclusions in early mixed must be immediately recognized and must be also urgently treated. Okay? So not only on the deciduous, but in mixed as well. In mixed dentition, we have many things to do. We can help our patients a lot. Okay? Some malocclusion must be immediately treated by intercepting. And skeletal discrepancies must be recognized and discussed in our diagnosis. Asymmetry development must be immediately recognized and also avoided. So many things we can do to our kids to be a very healthy adult. When come the permanent stage, it's just a simple alignment. It's going to be super good and very easy money in your office. But if you have this for the latest, it's going to be a case of really much more in trouble and harder to treat. So eruption of the premolars now is a very important factor in what? In limiting the rotation of the mandible, because the bicuspids are in the position to limit rotation, and also to guide and maintain the mandible forward. So you have basically two bicuspids. One bicuspid, second bicuspid is responsible to maintain the case in rotation and closing. So second bicuspid is very important to stop the vertical rotation. And the first bicuspid is super important to guide and slide the mandible to forward position. So if we extract the first bicuspid, I have trouble to later maintain the mandible class 1. The case becomes very easy to relapse because to maintain the mandible class 1 in our occlusal system, I will be 100% dependent on the first permanent molar to the end of the life. Okay? So if I extract first bicuspid, I will lose the capacity to guide the mandible into class 1. So the case becomes very unstable. So the retrusive control is going to be on the first premolar. And here, it matches with the puberty. So the puberty, the kids become very, let's say, psychologically stressed in the second moment. So we have a big period of stress between 0 to 6. We have a gap, and now puberty, stress again. So these kids start to again have severe bruxism and so on. The bicuspids at the moment are very important to maintain the vertical dimension. If we extract the first bicuspid at this age, we will cause to the patient a difficulty to maintain the mandible forward, especially in this moment of puberty. Okay, so to summarize what we just spoke, at the end, what we want to do to see here, like a progressive positive Wilson curve on the upper jaw, a little negative Wilson curve, positive but lighter negative torque on the lower arch, and a sequence from more torque on the posterior and less torque on the anterior. okay? Lesser the torque in the anterior. And you always see this little gap between the teeth, because this is the only way we can do lateral intrusion of the teeth without any interferences, okay? So don't put negative torque on the upper jaw, because this is very harmful for the joint. So then this is the sequence we have of positive inclination. And the canine end up the movement, so it's the canine guidance, but in fact it's like a progressive disocclusion. We finish on canine, and the canine guides the disocclusion of the molar. Okay, so this is how this system protects. If I have a very aggressive canine guidance, I will load the joint too much. This is sometimes good for prosthodontics, but not for the ortho. Okay, when we have full dentition. So protect the joint comes from canine, but not super aggressive. Must start on the molar and finish on canine. So canine dominance is important. To what? To protect the joint, okay? And impede molars contact. If we have molars in contact in the guidance, I will have a lot of interference in the joint. You certainly don't like, but later on, it will have a severe wearing of the posterior teeth and the periodontal breakdown in this area, fractures, destruction of the molars. So we need to protect the molars in our system with the canine, but not so aggressive dominance. It's going to be progressive from the molar and finish on canine. Okay? Good. So canine position is super critical to control this system. So we have also some overjet, some gap here, intercoronal leeway to allow the function. If I put the canine to in, I block the lateral movement of the mandible, and the mandible with this interference tends to slide back and also stay in class 2. So if you look to your cases and observe from canine torque, if your case is facing difficulty to reach the class 1, maybe because your canines are too steep. Okay? If you open the canine a little bit, it facilitates the mandible adaptation forward. So here, at the end, we have what? We have 3 areas of function. The red area, posterior area, is supportive to the joint. Okay? The orange area, bicuspid, is supportive for the mandible rotation, and the green area is the guidance rotation on protrusion and sideway. Okay? So we have these 3 very clear areas in our system. So, and also need to understand our occlusal system is kind of class T liver. Okay? The class T liver, it works like the fulcrum on the condyles, and the whole weight gonna be on the anterior teeth. And we have a pivot on the bicuspid area. So fulcrum on condyle, the weight in the incisors, the pivot area will be on bicuspid area. So this way we can maintain the system in rotation and closing and occlusion, and sideway will be protected by canines and first way. And by first bicuspid helps you to guide and stay class 1. That's the sequence, okay? Wonderful. So all the structures will be adapted over time into a new system when you have completely full permanent dentition. And condyles and the glenoid and eminence will be completely formed at age 12, which is canine already functioning in the occlusal system. So the eminence finished to form when we have canine. Okay? So after this is completely established, and we cannot change. So the formation of the eminence is based on the eruption until 12. Okay, until we have canines in place. Here is a picture of a tricycle, and where we can see the eminence height is always different in all patients. So every patient develops its own eminence height and on eminence inclination, and sometimes different left and different on the right. And this is very important to understand because our muscles, our closing muscles are all posterior. So our closing muscles are in the mandible on the posterior area. Temporalis, masseter, lateral pterygoid, and so on. Okay? Medial pterygoid. All of them are inserted into the mandible in the posterior area in the condyle. Ligaments to stabilize the mandible are also connected to the posterior area, and also the capsula is, of course, in the posterior area. So the whole important things in our occlusal system in terms of function are all linked to the ramus, all linked to the posterior area. The muscles who attach to the chin are linked to the hyoid bone. Okay, so this is helpful to open and close, but the real action happens in the posterior area. This is why we have it in our occlusal system the class 3 lever. Okay, because the fulcrum will be always on the condyle. Based on that, I need to understand that in the normal joint, we have a very important dynamic function. So when we open, we start from this point here, the center of the condyle, and we finish in this point here, where the patient will finish the protrusion or opening, closing, to get back, and this movement makes a curve. This movement makes a curve, and this curve is completely dependent on the shape and morphology of the eminence. So depending how is the eminence, this movement will happen. So some patients are in the moment of opening, closing, or protruding, retruding. It happens completely different movement of the mandible in this process because it happens on top of the eminence. Okay? Our joint is a sliding joint. Okay? So this is a basic function of the mandible, the TMJ, sorry. It's because our joint is sliding. Okay? So our joint is made to go forward. Our joint is made to slide forward, translate forward. We have rotation, of course we have rotation, but the main function of the joint is to slide. Okay? So then slide on top of the eminence. Okay, this is posted. I need to understand the dynamic trajectories of this eminence and the mandible over on top of the eminence. So static relationships are completely secondary. So I need to understand this relation in function. So if I take a CBCT or conicity of the joint in the static position, it's a very short information, very limited information. I would just learn almost nothing from this information. Because this is static. This is a picture of the patient at that particular moment. So the condyle and the eminence are completely, sorry, my voice after 10 days of teaching here is not so good. So this area is very important because we need to understand that we have a hetero area in the joint, and this hetero area in the joint is totally linked to the middle ear. So we need to be careful because if the mandible is back, many structures will be under trouble. And the cartilage on the condyle is very interesting. It's different than some other cartilage structures because it's always information, it's always growing, it's always adapting through life. So it seems like the nature understands that the condyle is fully in motion all the time. It receives a lot of impact of the occlusal forces, and this system needs always to keep adapting, keep forming, keep renewing. This is a system with a self reconstruction all the time. So this is the capacity of the condyle joint. And the condylar cartilage, you can see clearly here that the articular zone that goes directly to the articulation, there's much more cells quantity of cells than the more inner portion. So it's really, really incredible the capacity of the adaptation of this system. And when we see, for example, very nice condyle, I can see a completely different, let's say, input of the function. The cartilage is really more active. When I have a compressed condyle with a flat head of the condyle, the capacity is lowered. So it means that the condyle supports certain limit of load, and after beyond of this load, the condyle start to resorb. Okay, so this is very clear in the system. And when we decompress the joint, this cartilage is able to reshape the condyle back a little bit. Okay, not of course exactly as before, but at least gives to the patient a healthier environment. So sometimes because of this compression, decompression, the condyle becomes with irregular surface, and this irregular surface can lead to some noises, and this is not always a joint problem in the disc. Sometimes it's just basically structural bone-to-bone problem, something like we can see in this patient here. For example, a super hyperplasia of the condyle on this side, and this is certainly not going to be absolutely normal in function, and you certainly generate many different noises on the joint that we sometimes can be confused. This is a disc problem. So CBCT is good for what? To check the shape, to check morphology. What's going on with the morphology of the condyle, to see if what kind of, let's say, functional input the condyle is receiving during this functional process. Okay? It means that the condyle can be distorted in many ways. So depending how is the condyle distortion, I can suspect certain movements and certain compressions happening to the condyle. So it's very critical to understand, for example, this is some peaks like this. This is certainly flatter condyles under vertical compression. So this is very important for my diagnosis. This is to predict and to forecast and also to create my treatment plan and create my mechanics. So in adult patients, as I said, as soon as we have canines, the eminence is completely formed. If we compare to primates, our joint is totally different. And in primates, they have better protection to the joint because they have this kind of osseous apophysis in this area here. This apophysis protects the joint to be backward. We don't have this in our system. We don't have this protection in our joint. So our joint is very, very easy to always slide back. Okay? So our joint is very risky because it's very dependent on a good occlusion of the discs. So if the discs are not interlocked, okay, the joint can be in trouble. So professors Larichek call our joint as a risky joint. It's very easy to have problems. And nowadays, I usually ask to participants in my courses, what is the prevalence of the TMD in the patients in your office? And not for my surprise, but for my confirmation, the prevalence of joint problems is increasing every day in the office. So every day, more patients come to your office with TMDs. This is really a reality. So if we don't understand the interconnection between occlusion and joint problems, you cannot treat these patients. Okay? So, sometimes I ask to myself something like this: why the TMDs are increasing? Why they are coming now every 5 patients one TMD, or every 3 patients one TMD? 20 years ago in my office, because I'm 35 years already orthodontist, but I would say 20 years ago in my office, I didn't have this much of TMD in my office. I didn't have, okay? But now it's my reality in my office. I have TMD every day, okay? Every day I have to face patients with TMD. So this is a big thing, okay? And why this is happening, okay? Why? This is not a genetical problem. Because genetically speaking, we are the same. This is certainly an environmental problem. What is the environment connection to the joint? Is the malocclusion. Is the teeth. Okay? If we don't have mature enough occlusion, certainly I will have joint problems. And connected to the TMD cases in the office, it also surged a lot the quantity of class 2 cases in the office. I didn't have this much class 2 in the past in my office. Certainly I had more class 1s 20 years ago. Now I have a lot of class 2s in my office. You need to make this connection. Class 2 cases and TMD, they are together because the mandible tends to stay backward. So if the mandible is backward in adult patient, the risk for the joint problem is really much bigger. So have this in mind. Think about it, okay? So the glenoid, as I said, pass through a sequence of formation from no teeth to full dentition. Okay? So it goes from 0 to 12 years of age. And later on, it keeps adapting because the people are living longer, okay, with the teeth. Now, it's very common in my office. I treat many patients and I put brackets in patients 70 years old. It was completely crazy 20 years ago. Why? Because the people at the age of 60, 70, they're healthy, okay? And they have capacity to afford the treatment. And they want to have a healthy environment until they die, maybe at age 90 or 100, and they want to have the teeth, okay? So this is something to understand that the new, let's say, specialty to come to dentistry is going to be the geriatric dentistry, okay, or geriatric orthodontics, okay, geriatric occlusion control. So not only the sideway, but the glenoid fossa we need to observe from the sideway. So we have two inclinations in the joint to function. One is the eminence, another one is to the side, okay? So when the patient makes lateral occlusion, it slides on top of these surfaces. So we have inclinations here, here, and also AP. So the glenoid is not as you see from the side only, but from the top is like a mountain. So the condyle goes forward and lateral in a completely different manners. So we need to understand the inclination of these surfaces to understand the function of the joint when I will reconstruct the occlusal system of my patient. So this way and this way, okay? So sideway, I have to understand the collateral ligaments that maintain the disc on top and many other factors that I don't have time to go deep here, okay? But this is totally linked to what we call transverse condylar inclination, which is move this condyle to the side. So based on that, I need to understand now when I receive a patient that I have general aspects to look into and to plan my case to understand. So here, I would have what? I have here a maxilla and I have a mandible in the space, then I have the joint. Okay, the joint merely is a connection between the skull and the mandible. Okay, and make this connection to the temporal bone. Okay, in this way, after that, I have to put the teeth in here. If I am prosthodontist, I need to fulfill this gap. Okay, I need to put the teeth. But the questions now arise: in where? Okay, what kind of vertical dimension? What kind of inclination of the occlusal plane I will put here? Okay, what kind of guidance I will give to this patient on canine or incisors? Okay, what kind of guidance I will give to the molar? What kind of sequence of this occlusion I will put here? And moreover, what kind of vertical dimension I will put the posterior teeth to be supportive to the joint. And to work synergistically with the joint inclination. So it's just not put teeth somewhere, anywhere. Do not look this mild. So I put creating an overdenture to my patient, I can create a TMD that the patient didn't have before you put the teeth. Okay? So if patient edentulous, there's no problem. I put the, let's say, all four or protocol reconstruction to my patient, the patient develop a TMD. So why? Because you're not observing these factors in the planning of your treatment. So for prosthodontists, this is so critical. For orthodontics, we receive the teeth ready, okay? So kind of, we have certain limitations. But we can also unload the joint and go towards to ideal movement. So planning from the joint is very important. So what is the really important thing to understand when I go plan? What is the inclination of the eminence? So based on the inclination of the eminence, I can understand the amount of vertical dimension, amount of lower molars and upper molars inclination that I will put. In other words, what kind of spec curve I will put, okay? What kind of Wilson curve I will place? What kind of guidance I will give to this patient at the end, okay? So if I know the sagittal condylar inclination, SCI, okay, if I know the inclination, which is not only anatomical, but this inclination is functional, I will not be able to really understand where I will put the teeth. Okay, so the posterior facial height is completely dependent on this sagittal condylar inclination. Also, skeletal position of the mandible anteroposteriorly is very dependent on this, because the capacity of adaptation of the mandible changed dramatically with the degree of inclination of the eminence. I will need to measure the lower facial height. Now it's okay. Anterior facial height. Okay? Anterior facial height is when I put my patient in the articulator and I open the pin. When I open the pin of the articulator, I'm increasing the vertical anterior dimension. This is rotation in the joint. Okay, basically. And the occlusal plane that I will put will be based on the position of the lower incisor. So this is why every technician starts to mount the overdenture from the incisor. Okay? So to develop the occlusal plane, I need the position of the lower incisor. I need to define this position. In my occlusal plane, go towards the excite point on the rounds. Okay? After that, I will place the posterior teeth. So, incline the tipping of the lower dentition, the lower molars, are very important to define the spec curve. Okay? And here we have a new spec curve now, and I will certainly be very dependent on what kind of transverse condylar inclination or what kind of sagittal condylar inclination my patient has. Okay? So wonderful. Now I am able to understand that every orthoprosto treatment should be treated or should be considered in diagnosis from what kind of condylar inclination the patient has. Okay? So the mandible depends on that, the craniomandibular system depends on that, the position of the mandible is very dependent on this, and the height of the dentition is absolutely important to be defined from inclination of the joints. Okay? So diagnosis and treatment plan must pass through the SCI and TCI. So what kind of tools I need to find this? What kind of elements I can use? Well, let's go to the instrument. What kind of things I have to use to define this? I need to use everything that I have. Okay? Diagnose, the more diagnose is not enough. Okay, we always need more diagnosis, more diagnosis. If in the future they launch new equipment, use it. Okay, so the technology is here to be used. So MRI, CBCT. Okay, we can use the chondrography. I will talk about this later on. New X-rays, muscle palpation, mounting the articulator. Make every measure you can care. So we need to organize, but analyze. Okay. So when you make impression of your case, it's not to be on the shelf, it's to be used in your diagnosis. So diagnosis is so critical. So here we have the sequence that I would like to use in my office. First I have muscle palpation, joint palpation, x-rays, tracing, mounting models, RP position, check MRI, CBCT, and after I will see what can I do to my patient. So in kids, early detection of crowding, interferences, and side shift is very important. Check some functional problems like also some anatomic situations like big frenum, large frenums. They are very indicative the patient is probably in short vertical dimension. Posterior teeth eruption, very poor. We need to adjust this and check inclination, especially on the posterior segment of the occlusal plane. If you have a super mesotypic lower dentition, we need to be careful of this because very mesotypic lower dentition leads to interference, and interference block and lock the joint. It's very, very bad for the lock and for the function of the joint. So check this vertical position and the inclination on the lower posterior. And you see that immediately the joint reacts, flattening into this kind of bad inclination of the occlusal plane. Both sides, left and right. So takes your x-rays, takes your pictures, analyze carefully your pictures, match what you see in the patient in the frontal x-ray. Okay, see if what you see in the face is happening on the frontal. So you can see here many bone distortions, different vertical position, left and right side. They're completely different in vertical position. And here, what we call a situation as double occlusal plane, where the lower posterior are mesotypic and the anteriors are flat. So at the end, I have all those factors in our system, a distance to the plane of occlusion from Frankfurt or axis orbita to the occlusal plane. And now you can use also Ricketts analysis to check the lower facial height and position the posterior and anterior in ideal way. Okay, in prosto and order. Okay. Another important thing to check now in the case is a little bit later is some signals of the system overload. If the system is not good, you will see loosening of teeth, attrition, abrasion, many fractures, tooth sensitivities, cervical lesions, periodontal defects, torus development, TMJ pain, TMJ overload, resorption condyles, headache, backache, postural problems. This is a signal that the system is in collapse. So, good. So for dynamic evaluation, the instrumentation helps us a lot. So I don't want to see the patient from a static way. If I only X-ray, if I only have X-ray, I will only see from the static way, okay? Usually we don't have much time with the patient chair side, so it's better to have another way to observe the case in function. It facilitates a lot and gives you some dynamic in your office also. So this way you can have many things to do. From the image, as I mentioned before, MRIs is very important to check the joints, but combing is useful. cephalometric analysis, panoramic, and so on. From multidisciplinary teamwork, it's good to have a physiotherapy close to you, orthopedic consultations, osteopath, and many other things, okay? And from interdisciplinary approach in dentistry, we can use splint therapy, we can use the help of a periodontist, we can use the help of a prosthodontist to have a very high quality final control of our treatment. So in our systematic diagnosis, basically I will focus to you guys from now on 3 things. The chondrography, the articulator mounting, and evaluation of CPM, which is condylar position measurement. So these 3 factors give us a bunch of information for a diagnostic system. So chondrography, articulator, mounting in axis orbital plane, RP, ICP, CPM, and sometimes we're going to use a dental technician to help us to make a diagnosis in WhatsApp. We can use splints, we can use certain bite tests to check out our treatment plan. First of all, we need to understand a coordinate system, which is the 3 planes on the space. So the y-axis is transverse plane, the x is anteroposterior, and the z is vertical, okay? This is a coordinate system in engineering, okay? So we're going to use the same coordinate system into our diagnosis. So if I see the case from frontal or horizontal or sagittal, I will talk about the y, the z, or the x, okay? Not only the face is being analyzed from this coordinate system, but also the whole body. And if we talk the mandible alone, I will also use this coordinate system, okay, to find location of the mandible. The GPS you have in your phone also use this coordinate system to locate yourself in space. So we need a coordinate system to locate the mandible. To locate where is the mandible in the system. I need to locate where are the condyles in the system. So I need the coordinate system. And due to this, it's very important to find what is the hinge axis of the mandible. So it's a central rotation of the condyle, okay? The central rotation of the condyle is what we call, if we link the left and the right condyle central rotation, we call this line as hinge axis. Like an axis on your car, the 2 wheels, okay? We have an axis, and these 2 wheels are similar to what we have in the condyle. So we have them linked with a virtual line, okay? And this virtual line happens, the movements as rotation in both sides simultaneously. I cannot analyze in the mandible only one side, because every movement happens left and right. So this hinge axis is critical to understand, because if I try to find out this position of the condyle in a bad hinge axis, I will not going to see a curved line as I showed you before. Do you remember the curved line I showed in the video of the joint? So this curve happens from a very well located hinge axis. Otherwise the curves are not good. To do it, I need to find how can I record this movement. So I like to use this system, which is a magnetic system that will be transferred to the computer, and where you can locate the hinge and you can measure the movement of the joint all the time. So this system will be connected with, after locating the hinge axis, of course, and finding the coordinating system, it will be attached to the face with a face bow on the upper and the face in the skull, and another face bow on the mandible. So we have 2 faces bowed together. When the mandible moves, it records all the movements through this sensor. So basically, we will mount the cast in this coordinate system. Okay. Later on, I will transfer this coordinate system to the articulator, In the articulator, I can measure everything. And I have absolutely precise, 100% of precision, what's going on with the patient mouse in the articulator. So after that, I can take X-rays and use this coordinate system to also superimpose the X-ray in the same plane. So I have the articulator and the X-ray superimposed on the same reference plane, which is now hinge axis and orbital. And this hinge axis orbital we call axis orbital plane. After that, we can develop a VTO based on my tracing. In the VTO, I can reposition the mandible wherever I want, cephalometrically speaking, increasing the vertical posterior or the lower facial height, but having in mind also the inclination of the joint. So the system can, this software can tell you where is the condyle in position 0, and if I want to make the mandible forward, I can calculate this pathway of the condyle on top of the eminence, and I place the condyle precisely in the position that I want. And for prosto, this is super critical because I can calculate the inclination of the 7, the second molar, the 6, the first molar, and all the anterior teeth, little by little in a progressive manner. Okay? And after that, I can use a coordinate system to reproduce the patient's mouse. So now it's coming new softwares. I understand the 3D is here to stay. So the new softwares are coming to facilitate this integration to software, for example, like Exocad. Exocad is good for occlusal reconstruction. So summarizing, I need to have the hinge axis very well located. There are many systems in the market to register the mandible movement, but none of them use the hinge axis. So if you don't have hinge axis, it's completely garbage. So sometimes you can spend $15,000 in the system, which has no hinge axis recording. This is garbage because you don't know from where the condyle started to move. Okay? You must record the hinge axis, otherwise the system doesn't work. And I have here location of the hinge axis and the movement being recorded by those sensors. Wonderful. So what can I do with this system, which is condylography? The condylography gives me tracings, gives me calculation of the SCI, calculation TCI, calculation of the height of the occlusion, calculation of the inclination of the split curve, calculation of the inclination of the Wilson curve, and calculate the pathway on top of the incisors and the amount of canine guidance. So you can do all the plan on top of this. So it's super nice. So the condylography gives me all these things. And at the end, if you want to have a WhatsApp for your diagnosis, or if you want to deliver a patient, for example, as claimed or by test, it's possible. So I use upper face bow like this, okay, and a lower face bow like this. And all those two systems will be connected with a sensor, which is the TMJ of the system, okay? So all the movements of the mandible will pass through this sensor, which will record rotation, translation, and sideway. So the three reference planes, the Y, the X, and the Z, will be recorded through this sensor, okay? So this sensor has two styles, and this is magnetic. You can record everything. First of all, I need to find mechanically where is the hinge axis. Later on, I need to place the sensor in the position that the computer can receive this information and transform this information in something useful for your client. Okay? So we need a software that will read the movement from this sensor. So this is a patient in my office. When we use the condylography to record everything, and I have a computer, and my assistants help us to make this movement. It's always very useful to train your assistants to help you and also do by themselves as this exam. Nowadays, I don't do myself in this exam in my office. My assistant, my nurses, they do it. Okay. So when I receive patient for me to diagnose and to read, this is already everything ready with the case mounted for me in the articulator. So I don't make this anymore. But in the beginning, certainly yes. To train my assistants, I must know what I am doing. Okay, so this is when the system is completed. I can record the movement of the mandible the way you see in the movement in this movie. So I can see translation, up, down, side to side, protrusion, intrusion, everything. All the movements can be absolutely measured from this system. So after that, the system will trace for me coordination lines based on the coordinating system. So I will see the lines when the patient is opening, closing, in protrusion, intrusion, or side movement, or shewing. I can reproduce any functional movement of the patient. For example, I can reproduce shewing, I can reproduce breathing, I can reproduce speech, I can reproduce side movement, or anything you want. For example, I want to see what happened to the joint if the patient bites only on the first bicuspid. You can record. If you can test your crowns before cement, you can do many things. So it's a super interesting system for your diagnosis, treatment planning, but also to refine the result of your treatment. Here is when I make the record of the maxilla. So the maxilla will be recorded in same axis plane of the joint. So the maxilla now is not recorded based on Frankfurt, but based on a functional plane through the hinge axis. So this is the real hinge axis position, and the maxilla is being recorded based on that. After that, I mark some points on the face of the patient using some metallic balls. So this is the orbital, and here is the hinge on the right side of the patient, and I make hinge on the other side of the patient. So I have 3 points, which we can construct the plane. So left, right, and orbital. And when I take X-ray, I can see these little balls, metallic balls. This is the hinge axis of the patient to orbital. And I can trace here a new reference plane from the side. And this is a new reference plane in the frontal X-ray, completely connected to your articulator. So the articulator is exactly the same as you see in the X-ray. It's 100% reproducible. You can see here in the joint, the points you use as a rotational points to mount your case. So the articulator now become the best way to analyze what's going on in the patient. So if I mount the models up and lower in hinge axis like that, I can see everything. And your articulator also reproduce the reference planes in Y, in X, and the Z. Okay? So what kind of information we can do from now on? Now it's super interesting how the software can give you. If you see here in this picture, this box of this articulator, I can customize everything. I can customize the inclination of the joint. I can put here the inclination of the eminence. Here's the glenoid itself, and here's the eminence. And I can also adjust the Bennett or the TCI based on the information the computer gives to me. So the computer gives me that in this side, the inclination of the joint on the right is 41 degrees with this kind of arthrotic movement of the joint. The joint is too flat. So when I do any movement on the joint, it's going to be on top of 41 degrees in a flat surface, okay? On this right side. On that side, the computer tells me, oh, this side is 44, and here is also flat. So I can say this patient is arthrotic in left and right side, okay? Because both both pathway, left and right, are straight. So no joint makes straight movement, always a curve. If you see straight, it's because it's arthrosis, okay? On bending movement, on this side 22, and this side 0. Perfect. I can program my articulator. I put everything that I need inside these boxes, and now I can move with forward the mandible, 4 millimeters, 2 millimeters, 1 millimeter, 3 millimeters, doesn't matter, but without any risk to compress the joint during this movement. So when I move the mandible forward, I will respect the functional pathway of the joint with zero risk to compress any structures in the TMJ. Okay? Wonderful. So, for example, if I have here a 7-year-old patient, just an example, SCR 44, if I place this patient in anteriorly 2 millimeters and downward 2 millimeters, so 2 millimeters down, 2 millimeters forward, for this patient, I have no compression. I can go forward without compression. But I am not decompressing because I'm on top of the curve, okay? Same patient, same quantity of activation, but different SCI, now 29. 2 forward, 1 millimeter forward, 1 millimeter down. This one is gonna be under the curve and certainly decompress the joint. So sometimes we are used to think, I will move forward in 2, down in 2, forward in 2 millimeters down. Sometimes for certain cases this is okay, but in certain other cases this is very bad. Because depending on how is the inclination of the joint. For another example, for here, if I put 2 and 2, there's no decompression, it's 44. But if I put 2 and 2 and 29, this is too much downward. Okay? You can have a loose joint in this situation. And if I have another case, and I put 2 and 3, I will certainly compress the joint in this situation. I will push the condyle against the eminence. The condyle will be on top of the eminence and will compress it. If the patient is 29 SCI, there's no problem. So be careful when you move your articulator forward and down if you don't know the pathway of the joint. From CBCT and MRIs, I can see, as I said before, morphology. I can see completely resorbed condyle, as you see here on the left. On the right, I can see a flat head of the condyle, which is completely different. So in this right side, I can see vertical compression. And this side here, I can see certainly a backward compression. So in the same patient, you can see different vertical dimensions and different position of the mandible inside the glenoid, okay? And MRI tells you where is the disc, okay? I cannot see the disc in X-rays. So in the MRI, I can see, for example, if the disc is on top or if the disc is displaced anterior like this or sideways like this, okay? So depending on how is the configuration of the eminence, the disc can be in different positions. For example, this is a normal joint. The disc is usually 12 o'clock with the bilaminar zone, so 12 o'clock is good. In certain cases, the disc can be like 11, and the disc is going to be a little bit more on top. In certain situations, the disc is displaced more anterior, like this. So depending how is the morphology of the eminence, different positions of the disc. And now, from axis orbiter, I can define the ideal vertical dimension to place the disc without any chance of compression. Okay, no risk. And also very important to understand the sideway movements of the condyle generates certain kind of rotation to the other side and generates an inclination pathway on this working side. Okay? For example, this is a Bennett angle for us to program the articulator for disocclusion of the system, what kind of canine guidance you're going to put, and what kind of Wilson curve you're going to put based on this inclination. So basically I have all the information, but another thing I like to do with the articulator is to measure the movement of the condyle. We call this CPM, which is condylar position measurement. We can use articulator paper, so I put the maxilla in place. You're going to see. Let me show the sequence for you guys. So we disassemble the articulator, use the upper portion to mount two boxes. Those boxes I install here in the articulator. So in these boxes I glue here, I tape here like articulator paper to mark the position that I want. So here I can cut here on the transverse sense, and I mount another one, and I mount the mandible and the maxilla in RP position, okay, which is the most posterior position without any compression in the joint. In this position, I mark a dot, and I release the maxilla now and put in maximum intercuspation now, okay? After I mark RP, I put the maxilla in maximum intercuspation and I mark another dot with another color, okay? And I can see the movement of the condyle. From first contact to maximum intercuspation, what is the movement of the condyle? Is to the side, is cranial, is downward, where is the movement? So I can measure clearly here what kind of movement the condyle is doing. In this particular case, matching perfectly, it's totally zero, okay? RP in ICP is the same. But certain cases, no. I can have 0.5, 0.3, 0.1, 1, 2, 3, 4. So this way, I can measure where is the condyle after the first contact. So I can use the articulator if you don't have, for example, condylography. You can use the articulator to measure. It's super useful to reposition the mandible in space and to re-guide the mandible in your articular plane. So after that, I can calculate the inclination of the occlusal plane. So I have now inclination of the occlusal plane, inclination of the lower dentition based on the SCI number. So you can have the ideal speed curve. So I'm going to show you some cases to exemplify what is this. So you will understand what happened, okay? So this case, with the disc dislocation, so I prefer to bring you some TMD cases, okay? So TMD cases are interesting because you can treat with this system super easy way, okay? So with this dislocation, for example, I treat this kid in the past like a traditional way. I expand her case, I put the quadrilex, I put fixed brackets, traditional way, okay? So like this. We expand, this is her panoramic, frontal, lateral X-ray, no big deals on her tracing, she's just a little convex, little short facial height. Facial height is basically okay, not so bad. So I started with the quadrilex. So I base quadrilex here. After quadrilex, I derotate molar and expand her. And at that time, 2009, I didn't have the same concept I have now. I could at this moment start to reconstruct the occlusal surface of the deciduous teeth. I could use the articulator and put her in ideal vertical dimension, but at that time I didn't have this concept, so I wait for the teeth. So after the phase 1, I wait for the teeth. So now they ideally would be a reconstruction. So I wait for bicuspids, and when the bicuspids start to come, she becomes more defined, obvious, but her face now is much better and more symmetric. She's nice, her smile is much better. And now the bicuspids are coming, canines are coming, so I take another X-ray here, So she's symmetric, still with certain interferences here, a little divide. Transverse dimension, and after I treat her, align everything and adjust with brackets, I finish like this. This is 2013, and I see this girl again 4 years after. This is her follow-up 4 years after. So still very stable, very nice. This is the occlusal view. Her panoramic 4 years after, she's missing one third here.